Chapter 12, Lecture 2, The Conduct and Performance of the Physician Services Industry. In the previous lectures, you learned about the market analysis of the physician services industry, looking at the market structure element by looking at the number and proportion and distribution of the physicians in different states and by type of specialty. You also learn about the barriers to entry. In this lecture, you will learn about the market conduct and performance. In addition, you remember that from the previous lecture, market structure interacts with the economics objectives to establish conduct. So means that any basically, for example, imperfect information or asymmetry of the information asymmetry impact the profit maximization or quality maximization incentive, and also any effective various compensation schemes may actually affect the physicians' behavior. So this basically very complicated relationship, correlation, interaction that we learn because of the imperfect information in the healthcare system. So the supplier-induced demand hypothesis refers to we call that SEED, refers to the exploitation of this asymmetric information to increase demand for physician services. What happened? The assumption is that the physicians abuse their role as a medical advisor to advance their own economic self-interest. So they prescribe medical care beyond what is clinically necessary, such as additional follow-up visit, excessive number of medical tests, or even the unnecessary surgeries sometimes, right? So this is because of the asymmetric information, and consumers, because consumers are relatively ill-informed concerning the proper amount of medical care to consume, and even they don't have enough information about their own real status of their health. So in that case, physician could possibly basically play a major part in determining the level of the demand for medical care, which is very could be very significant. So graphically, when we wanted to look at the supplier-induced demand model, we have the regular supply and demand. So this is the regular supply initially, and with the red, and then we have the demand with the curve with the red. Assuming that the intersection of the demand supply for physician services initially is at the point of P0 and Q0, right? Intersection of supply and demand in the red line, basically red supply and red demand, and then it's basically P and Q gives us assume in the first scenario, assume initially that the market for physician services is in equilibrium at the point of P0, Q0 from the demand and supply D0 and S0. Now, suppose that in the scenario 2, what happened, assume that there is an increase in the number of the physicians practicing medicine. So that could be because of the number of the graduated medical students from the school, or because of the increasing the number of the physicians immigrant to the United States. So that actually shifts the supply curve to the right, and usually by shifting the supply curve to the right, what happens without any basically external effect, that decrease the price and increase the quantity. So rightward shift of the supply curve always decrease the price and increase the quantity without any external effect, right? Just without any basically other effects. So we are talking about only rightward shift of the supply curve. Now, if in reaction, in the scenario 3, if in reaction to decrease in the price of the medical services, physicians increase the demand for services and shifted demand curve to the right, and then in that case, so rightward shift in the demand curve always increase both price and quantity. Now, the final effect, so means that the basically that by rightward shift in the demand curve with this size, we end up with the higher price and higher quantity. Of course, usually in the reality, the final effect depends on the size of the shift of the demand and supply. So if the size of the demand is smaller than the rightward size of the shift of the supply, then that actually decrease the price and increase the quantity. So you have to again pay attention. So the first in the first scenario, the supply and demand interact at the point of P0, Q0 by rightward shift of the supply curve because of increasing the number of the physicians or practicing. We have a decrease in the price of the physician services and increase in the quantity. And then if the physicians, they are unhappy with the decrease in their physicians services price, and they actually increase the demand by unnecessary procedures, so that may shift the demand for medical services to the right, and depends on the size of the shift compared to the size of the shift of the supply. So that actually may increase the price. The quantity definitely is going to be increased, but the price depends on the size of the shift. So that actually is quite a concern, because when we were checking this scaling scale based on these characteristics, we know that there are so many physicians in the market, so they can have a market power because there are so many of them, right? But the point here is that although the physician services industry appear to be structurally competitive in terms of actual number of the physicians, based on the practice variations and the supplier-induced demand that you just learned right now, behaviorally, physicians may act with some market power. So they can actually have a huge impact in our medical care expenditure by their market power. So the supplier-induced demand hypothesis model indicates that the physicians hired to address the health concerns of the patients, principals, so the empirical evidence on this seed says that so the surgeon, for example, induced demand for surgeries, and by size we can say that 10% increase in the supply of the surgeon in the practice as measured by the surgeon to population ratio leads to 3% increase in the per capita surgery rate. Sorry, this is per capita. There is a typo here. Per capita surgery rate. And then first, so these are the studies. Basically, they have provided different range of the effect. Also, support for seed weakening in recent years, and some of the other study, they say that a few authors attributes the greater demand for surgeries to improvement in access, lower times cost, and better quality. So the studies, by using the physician-based practice data, more sophisticated model, and contemporary data sets, they found that so increasing this demand is not because of the false basically prescription because of the unnecessary increase in demand. Maybe this is because of the improvement in the access, lower time cost, and better quality. So there are basically contradiction in the evidence, whether so we have really the supply-induced demand in our market increasing the demand by unnecessary prescription, or is because of the improvement in the access or lower time cost and better quality. Now, so looking at the impact of alternative compensation schemes on physicians' behavior, we are looking at the conduct, right? So there are two main different alternative actually reimbursement. One is the fee-for-service method of payment, which creates incentive for overutilization of the medical care, because the physicians are reimbursed by number of the time the patients are basically coming to their office, right? So in that case, when there is no incentive for the physicians, they can say that, okay, just to the physicians without any need, they can say that just come next month because that actually increase their profit, right? The pay-for-performance payment schemes at the beginning, it was very kind of increasing the hope that can provide incentives to healthcare providers to improve the quality and or reduce the cost of medical care provided. So that performance basically could be measured based on the clinical outcomes or clinical process or patient satisfaction or cost of care, basically how many patients they can treat. That was basically at the beginning was very there was a high hope for that. But then there is no evidence of ultimate health improvement for patients. And this is because maybe the rewards are very small, and the physicians basically, they have other factors for maximizing their utility besides the extra little income, such as increasing their leisure time. The other case is the impact of utilization review on the physician services market. So the utilization review is one of the most frequently used methods to contain costs. So by basically the prospective, concurrent, and retrospective reviews to evaluate the medical decisions of the hospitals and physicians to minimize the medical costs by eliminating the unnecessary medical care and by educating patients and physicians concerning proper medical treatment, right? This seems very basically kind of optimistic because, by providing these kind of guidelines, you can give this information to both physicians and patients. What is the basically steps they have to take for treating a specific disease, for example. But the empirical evidence indicate that the combined impact of both although initially the empirical evidence indicate that the combined impact of both pre-admission review and concurrent program has been decreased hospital inpatient days by about 12%, and also Blue Cross Blue Shield utilization review programs decreased hospital patient days by 4.8% and inpatient payments by 4.2%. There are some evidence shows that physicians eventually learn to game the system and how they can actually fill out the paperwork to basically, if they want, to maximize their own profit by increasing the demand again. So the impact of utilization review on physician services market seems that the basically kind of good idea. The development of clinical practice guidelines for physicians provide physicians and patients with the preferred method of treating different types of medical condition. So the objective is to improve the quality of medical care and to lower the cost by providing timely information to physicians concerning to the efficacy of the various medical procedures. The other way of looking at the performance of the physician services industry is looking at the medical negligence, right? So your outcomes of your work should be based on the basically positive and negative outcomes. Using the medical claims data in 2008, Shreve and Van den Bos, they found that 1.5 million patients suffered the negative consequences of medical error, 13,000 for the average total cost per error, $13,000 per average total cost per error, just per error, not per patient. And then 19.5 billion for the total cost of the error. So from this total of the 19.5 billion, the 17 billion was attributed to the direct cost, 2.5 billion was identified as indirect expenses, and then so this indirect expense usually categorized to two types: productivity and short-term disability. So these are, although not in the healthcare cost, but they still should be included, right? Because there are consequences of the performance of the medical care. The medical errors caused over 2,500 deaths in 2008 and over 10 million days in lost work due to the short-term disability claims. So looking at again, these are all because of we are going to relate that to the imperfect information. Just pay attention. The medical negligence and defensive medicine, again, from the empirical studies, we see that 3.7% of the patients experience a medical injury. Of those, 25% were the result of medical negligence, and most of the injuries were minor with complete recovery occurring within 1 month. So the point here is that the 2.6% resulted in total disability and 13.6% resulted in death, but only 2% filed a malpractice claims. The large number of the claims filed with little evidence of negligence, basically. Now, the defensive medicine is very important in our healthcare system, for the cost of healthcare system and for evaluating the performance of our healthcare system. 93% of the physicians reported they sometimes or often engage in at least one of the 6 forms of the defensive medicines outlined in the survey, and the 59% of the respondents report that they often order more diagnostic tests than medically necessary. So this is also basically 70% of the ED physicians. They, because of the problem, because of they are afraid of medical negligence, they are over basically prescribing about 59% of these people responded only. They order over basically diagnostic tests because of they are afraid of basically medical negligence. So that's a huge actually problem in our healthcare system. So the medical negligence end up to the higher utilization, and most of our physicians, basically 93% of our physicians, they're working on something else engage in at least one of the 6 forms of defensive medicine rather than caring for the patients. So these are all negative impact on our performance of the medical care. So looking at the imperfect again, by imperfect information, we mean that we are trying to see what are the 2 primary goals of malpractice system. So that's a malpractice liability system is performing properly when the last unit of precautionary care, the marginal social benefit is equal to marginal social cost. If we are spending more on malpractice liability system, means that the marginal social cost is greater than marginal social benefit, means that there is an inefficiency in the market. So the malpractice liability law is compensates victims for the 2 primary goal of malpractice system is to compensate victims for any damages caused by the negligence of healthcare provider and helps deter healthcare providers from engaging in future acts of negligence. So physicians are also, frustrated because of the liability costs, because of the medical malpractice insurance costs they have to pay, and also because of the defensive medicine. So what happened? They have to overutilize the medical services, to basically so it's increasing the cost in the medical expenditure. Now, looking at the performance of the physician services that have contributed to the increase in expenditure on physician services over the past decade, we see that physician expenditure increased by more than 3-fold from 1990 to 2010, and I will show you the graph. The consumers in the price index doubled. So the difference between these 2 should be related to the physician's expenditures. Now, there are 2 reasons. Final effect could be because of the increase in expenditure on physician services financed because of the increase in utilization, which is related basically to quantity, or could be the result of increase in practice costs because of the price in unit, basically increasing the price of the medical care. And we wanted to know what are the share of each of them. Looking at the expenditure on physicians and clinical services, so this is basically the table for the expenditure on physicians and clinical services. The expenditure on physicians more than 3-fold from 158.9 billion to 515.5 billion from 1990 to 2010. Now, you have to consider that we have inflation, we have to adjust for inflation. So we usually use the consumer price index to adjust that. If we look at the inflation, we see that the CPI doubled. So this is tripled and this is doubled. So the rest of them basically should be related to the increasing in the physician expenditure. Therefore, we can actually calculate how much. We say that 100, and this is 158.9. This there is a so 515.5 minus 150. I'm sorry. These are the nominal costs. So we are going to actually look at the real cost actually change. So after adjustment for the inflation, we say that from the increase from 155.6 from 98.8 divided by the base case. So 155.6 minus 98.8 divided by base base cost or expenditure, which is 98.8, gives us 57.4% is the change basically due to the expenditure on physicians. Of the average annual increase in physician expenditure was the result of the price increase, while the rest was due to the increase in utilization. Now, the real expenditure on physician is found by dividing the nominal value of the relevant CPI. So let's see here. The real expenditure grew by 3% from 1990 to 2010. In 2010, the nominal expenditure increased from basically 10.9% to 1.9%, while the real expenditure actually fell a little bit, which it doesn't show here, and we have to calculate that. You don't need that. So looking at this graph is the consumer price index for physician services. And the consumer price index for physician services is from 1990 to 2010, increased by 100%. So the middle one is the consumer price index for for physician services. And the last one is the consumer price the last one is the consumer price index less medical, and the middle one is for the physicians, and the top one is for the medical one. So we wanted to know the consumer price index for physician services for 1990 to 2010 increased by 100%. So looking at the middle one from 166 to 331.3 in this point. So from 166 to 331.3. Now, the CPI less medical care means that the last one, the bottom one, is increased by a little bit more than 63%. So the average rate of inflation for physician was twice that of the overall rate of inflation, less medical care. So the rate of inflation for physician services was slightly less than the rate of inflation for medical care. So as you can see at the top is the rate of inflation for the medical care, and as you can see the rate of inflation for physician was slightly less than the rate of inflation for medical care, and this disparity appears to basically increase over the time. So from all these we can say that we are looking at the performance of the physician services industry. One of them is looking at the medical expenditures, all right? That's one of the performance of the physician services. So the inflation of the physician fees overstated because so all these changes is not inflation. First of all, the figures fail to consider any improvement in quality of the excuse me. First of all, the graphs fail to consider any improvement in quality of physician services, and also the graphs figures do not adequately reflect many of the technological improvements. So we have to consider those. Now, the performance of the physician services industry, the last thing we have to look is the physician's income, right? That's also shows the performance of the physician services. When we look at the nominal income, remember that we have to look at both nominal and real. The nominal means that not adjusted for inflation, and real means that after adjustment. So the nominal income increased from 158,000 to 189,000 between 2002 and 2010. And this is basically shows the increase of about 20%. But when we adjust for the inflation, we see that the real income decreased from so there is a typo here, from about 158 to about 156,000. So That actually is not surprising because of the growth in managed care, which basically controlling the physicians, you know, basically work, increased use of the financial incentive dictated toward physicians. So it doesn't, the managed care organization, they kind of watching out the physician to not to increase their basically unnecessary procedures or basic number of the visit based on to maximize their own economic profits. And because of the implementation of the tighter fee controls by the Medicare and Medicaid programs. Now, the evidence, previous studies, empirical studies shows a 10% increase in the HMO enrollment from 20 to 22% is associated with the 2.6% decrease in physicians' earnings. So that actually really shows that the reason for decreasing the real income of the physicians, the annual rate of return on educational investment, if we wanted to compare to the other professions' income, the annual rate of return on educational investment for physician is about 16 to 21%, and if we wanted to compare to the business people, is 29%, and attorneys are 25%. So, and then this graph shows the real decrease in physicians' income over the past few years. Finally, let's see about the Affordable Care Act. Provisions of the Patient Protection and Affordable Care Act of 2010 relating to the physician services market says that so there is an increase in the number of physician visits, right? So that Q basically increasing in quantity by more than 30 million people. So that's expected basically increase by increasing the number of the people they have insurance, right? So then, of course, based on this is based on the previous estimation before planning to repealing the Affordable Care Act. So it was supposed to be increased by 30 million people. And there is, so that increased the revenue for physicians by Affordable Care Act. So exacerbate the looming shortage of the physician, how we can actually decrease the shortage of the physicians. They plan to address the shortage of the workforce by providing different scholarship and a student loans forgiveness program for medical students. And also the plan was still is adjusting the fee payment schedule for Medicaid and Medicare because previously Medicaid patient, they had the lowest payment schedule, and there was very little incentive for the physician to accept the Medicaid patient compared to the private patients, to the patients with private insurance or patient even with Medicaid insurance. So, but right now they in the Affordable Care Act they plan to adjust this fee payment. So the other plans where primary care providers and general surgeons will have the opportunity to receive bonus payments on top of the regular fee payments. And the other plan was and still is the formation of the Independent Payment Advisory Board to provide recommendation to Congress regarding the Medicare spending. Remember that we have to consider the impact of physicians, all these management care organization impact on physicians' autonomy and mode of practice still continues, that physicians are basically transferring to bigger practice to work together or being hired by the hospital rather than having solo basically practice. Formation of the Accountable Care Act is accountable for triple aim: improving the quality, improving the access, basically increasing the access, improving the quality of care, and decreasing the cost of care. Support for the comparative effectiveness research that will assist physicians in making informed decisions, and provides demonstration project grants to states to develop, implement, and evaluate alternatives about malpractice. This is the end of chapter 12.